Hello, my name is Jessica Bean, and today we are going to talk about patient satisfaction and HCAHPS scores. So, patient satisfaction plays a really big role in reimbursement. Through the use of surveys, we're able to give our patients a voice and hear them. The Hospital Consumer Assessment of Healthcare Providers and Systems, which is in short known as HCAHPS, is a key survey that the Centers for Medicare and Medicaid Services have made mandatory for all hospitals throughout the United States to use. This survey evaluates both the doctor and the nurse's communication skills, their responsiveness, the overall cleanliness of hospitals and facilities, pain management, patients' overall experience, and more. While this can be really beneficial and help us focus on areas that really need attention and need improvement, there are numerous things that factor into patient care that patients and patient family members are not really aware of. So today I have with me Jana MacArthur to discuss HCAHPS scores and patient satisfaction where she works at. So let's kind of just start by getting to know you a little bit better. Where did you go to school and when did you graduate?
I went to the nursing program at Chipola and graduated in the fall of 2010.
Okay. And what facility are you currently working at?
I have been working at Southeast in Dothan ever since I graduated. I did my preceptorship my last semester in the emergency department there and fell in love with it. So.
Okay, so you currently are working in the emergency department?
Yes.
Okay. And how long, or what position do you have?
I am a supervisor on day shift.
Okay. And how long have you had a supervisor role?
About 3 years.
Okay. So if you're a supervisor, you're pretty familiar with the HCAHPS scores, right?
Very.
So how important would you say they play in your department?
They are very important. We have a lot of processes that focus solely on patient satisfaction, which they're sent out usually 48 hours to 6 weeks after patients are discharged, and it is random.
Okay. I feel like with them being random, that already puts them kind of at a disadvantage.
It does.
Because if you have like 10 patients and, out of 20 that you might see and 18 of them are, well, I guess if like 15 of them are happy with their care and 5 of them aren't, but, more of them get that survey, does that make sense?
Yeah.
Then your scores are automatically going to go down.
Yeah, it's a big disadvantage.
Yeah. So what ancillary departments play a part in your department for patient care?
Environmental services, pharmacy, case management, the laboratory department, patient placement, and radiology as well.
So it sounds like there's quite a bit of departments that kind of all
Involved.
blend together to help out, but give me kind of an example of how a department can affect care.
Well, we are a level 2 trauma and stroke center. We get a lot of stroke transfers in due to having the interventionalist Dr. Wapham. Meaning if we get a stroke or a trauma that comes in the door, it can put an extreme delay on the other patients having their labs returned. For example, if a stroke comes in, we draw the blood and their blood is the priority at that time in the department to get done, as well as traumas. And radiology, usually there's 2 x-ray techs and 2 CT techs during the daytime hours. But if a trauma comes in, that takes up a lot of hands. their scans
So
are a
they-
priority.
They kind of put the other patients on the back burner.
Yeah, and for the radiologist as well, because their scans are a priority for him to read. And also they usually read for multiple hospitals at a time here locally. Which we are a 420 bed hospital. Our ER can hold 32 beds, not including wall beds if we need to use them for less urgent patients. But like I said, usually being a trauma and stroke center, that can play a huge role in increasing the length of stay for some patients.
For sure.
And that patient may be the one that gets the survey that day.
So what steps are you taking in your department to help increase HCAHPS scores?
We have several processes that have taken effect in the past couple of years. We do daily huddles on each shift, usually 3 to 4 times a day, that we huddle with the nurses coming on, keeping them updated on processes, what's going on that day in the ER, and just reminding them what needs to be done to improve patient satisfaction. We do leadership rounding in the ER where myself and other supervisors will go round on approximately 40 patients a day, just seeing how their visit's going, making sure they're happy with their care, their nurse, their doctor, everybody that's involved. We do also have our emergency department techs round on patients when they don't have anything else going on for comfort and safety measures, seeing if anybody, their family needs anything, pillows, blankets. And they also do have rounding boards up on the med-surg floor. They're required to go in there and lay eyes on the patient so many times a day on day shift and night shift. We did change to a new zone system over the past year and a half, which drastically improved our numbers, decreased our length of stay, which in turn made patients very satisfied. They're not sitting in the lobby as long. We usually have 3 nurses and a doctor in each zone, and usually we put a tech in that zone as well. And like I said, they're responsible for rounding on their patients in that zone throughout the day to make sure there's not anything else we can do to make them happy.
You guys have had a pretty positive outcome to this new zone.
We have. It was a difficult change because it's been that way long before I was there, but it has drastically improved our numbers, decreased our LWATs, which is our left without treatments, which is increased money and made patients happier. We do have a PA, physician's assistant, that we put out front of triage with a nurse when the staffing is sufficient, and emergency department tech. The goal is for the provider to be able to see the patients upon arrival, decrease our LWATs, and get things rolling really early in the process, order protocols, and things that they think is necessary. Go ahead and have the nurse and the tech draw that blood work, get those x-rays done from the lobby, so by the time they get back to the back to see the physician, most of their stuff is usually returned. If we don't have a PA that day at triage due to staffing, we do have nursing protocols that we can order that all our physicians have signed off on that consist of lab work and x-rays if the patient meets the criteria.
And are you guys constantly meeting and coming up with different ways to help increase? Because I feel like, once you swapped to that zone process, everyone was so excited because you're going back to see the doctor, and now it's like expected, so now people are getting upset again, and now LWATs are increasing.
Right, and our volume is very high. Like I said, with us being a trauma and stroke center, we do have a pull to full process where if there's an open available bed, if a patient checks in, we pull them back immediately, triage them in the back instead of at the front, but when volumes are high and there's not always beds open.
Sometimes there's just things you can't do.
Right, or the hospital being full and causing us to have boarders in the ER due to no beds available, which has been a problem throughout the whole state this year.
It's been a bad flu season.
Flu, behavioral medicine, no beds available, critical patients. We also have put on a section of our discharge paperwork a special area to let patients know, if they need anything after their care is complete with us, how they can follow up with case management, a number to get a hold of them, things they can do to avoid another ER visit or hospitalization. So we really discuss that daily, multiple times a day in the huddles with the
Your
nurses.
members printed on that paperwork.
They are. We did have some low scores and complaints in the area of explaining medications, what they're being discharged with, who to follow up with. So that's something that we have expressed greatly in our huddles over the past couple of months, and our scores have increased drastically with explaining medications, the side effects when they're given them at the bedside, also with the prescriptions that we're giving them, and letting them know what doctors and specialties of who they need to follow up with.
So do you think that reimbursement should rely solely on HCAP scores?
No, I
I really agree with that. I feel like they are beneficial. Like I said, they allow us to pinpoint areas. Like you said, talking about discharge teaching,
don't.
you're able to get those feedback and able to come up with ways to increase that area. But at the same time, it's clear after talking to you and you kind of hearing about all that goes into patient care that it is a joint effort. It's not just nurses and doctors in the emergency department. It's like you said, radiology, lab, all that.
And it is important to hear what the patients have to say, because there's always room for improvement for every hospital and every department, but it shouldn't necessarily solely rely on that.
Yeah. I feel like we should always factor in like patients' overall outcome, because a patient can improve in the hospital and get a lot better and get back 100%, but just because they may be unhappy with something, or you know what I mean?
Pain management.
If they get that, they're that one special person that gets that survey and they leave a bad response even though they got better. That should also be factored into.
For sure.
Well, thank you for your time.
Thank you.